A new addition to the panel this year, a new perspective, is Bruce Witt, who represents the Via Christi Health System in Wichita. When we did this last year, there hadn't been a lot of experience yet with providing services, but we thought a year later it was really important to have the provider perspective represented on the panel as well. So please give all of them a round of applause and thank them for being here today. We look forward to hearing from all of you. And then Linda is going to start off. Linda, most of you know, I'm sure, is a lawyer who worked at KID for a number of years, was very involved in the ACA implementation in the state with the insurance department, and is now head of our health reform team at KHI. So Linda, take it away.
Great. Good afternoon. Thank you very much. I just wanted to make some really very brief comments to mention to you in the handouts that you have in front of you. We put a couple of things in there. There's some bio information about our panelists today. Also, there is some just a couple of slides with some preliminary enrollment data that we've gotten from HHS. We had expected to have the full complete report when we will be doing, KHI will be doing a full analysis of the demographic information that we have from open enrollment for this year, and I've been told that that'll be coming in a few weeks, and so we're looking forward to getting that, and we'll have a full formal fact sheet that we're preparing at that time. But I wanted to just give you a little bit of information that we had about the open enrollment period and a few of the data points, and I know Julie's going to talk about those in more detail. And then we've also included a piece that we did trying to summarize the oral argument that was done in earlier this month on the King v. Burwell case that could have an impact on the tax credits that are available to individuals in states like ours that are using the federally facilitated marketplace website. So that's in there for you, and as Bob said, I think we're going to start with Julie and sort of set the regulatory tone for it, and then move on from there.
My name is Julie Holmes, and I'm the Director of the Accident and Health Division at the Kansas Insurance Department. I was just going to provide a high-level overview of the marketplace in Kansas for 2015. As you all know, we have a federally facilitated marketplace in Kansas, but the Kansas Insurance Department has maintained its statutory authority over those aspects that are traditionally performed by state insurance departments. The department performs plan management functions. Kansas law requires the department to review all policies that are being sold in the state for compliance with the appropriate laws. And we also review rate filings and deal with consumer complaint issues as they arise. From a plan management perspective, the department uses several tools that are designed to standardize the review of health insurance plans for compliance with the various provisions that are required for them to be a qualified health plan. Essentially, these tools check that all plans meet a threshold for such things as essential community providers, that all plans meet requirements for maximum out-of-pockets, for deductibles and other cost-sharing requirements. It checks plans' formularies, and it looks for unusual outliers in the formulary and in benefit design. In total, there are 9 of these tools that the department uses. Currently, there are 5 companies writing on the marketplace in Kansas: Blue Cross and Blue Shield of Kansas, Kansas City, and then Blue Cross and Blue Shield Kansas Solutions, Coventry Health and Life, and Coventry Healthcare of Kansas. There are a total of 64 individual plans that were available in 2015 on the marketplace and offer, depending on the county of residence, all of the metal levels and catastrophic plans. There are 18 small group plans available that include gold, silver, and bronze metal levels. And there are 4 companies offering individual standalone dental plans and 13 companies offering the group standalone dental plans. Open enrollment began November 15th of 2014, and the last enrollment numbers that we've seen include the first special enrollment period that ended on February 22nd. And that report shows that there were 96,197 Kansans that had made a plan selection, and of those, 80% were eligible to do so with financial assistance. The average monthly premium before the advanced premium tax credit was $301. and the average monthly advanced premium tax credit is $211, making the average monthly premium after the tax credit $90. All of the health insurance plans sold on the marketplace do include the essential health benefits, and those premiums for those plans are allowed to vary by age, tobacco use, area, and family status. And when you compare the premium rates for all plans that were available in 2015 to those that were available in 2014, those premium rates remain pretty close to level. However, the revisions experienced for plans that were maintained from 14 to 15 varied in most cases, and in most cases those were revisions that were increases. The average rate revision for existing forms in the individual market by carrier ranged from negative 0.27% to 14.9%. Some of the main differences that we saw between 2014 and 2015, the shop is functional in 2015, but employee choice is not an option this year. The federal website has functioned better during the 2015 open enrollment process, and Kansans have an additional company to choose from when selecting their plan for 2015.
Okay. So Linda sent us an email last week and it had like 100 questions on it. 5 minutes, so I'll answer all those. Was that like 7 seconds an answer or something? I don't know. I'm not good at math. So I'll just give you sort of a general set of observations, and I'm sure that we'll talk about a lot of those other things in the questions. But generally speaking, I would say that we at Blue Cross and Blue Shield of Kansas have had what I think we would describe, and honestly to ourselves, even in a kind of a dark conference room alone, as a successful implementation. But it has not been an easy one. This has been a lot of change in a short period of time, and a huge learning process, particularly through the difficulties of the 2014 open enrollment period that I think have been well documented. You know, and it seems like it's stuff that we ought to be able to implement really quickly, but even things that might seem easy really are actually pretty hard to do for a company like ours that has a really strong culture around doing things a certain way. We've had to change a lot of processes. We've had to make system changes that we haven't had to make, really fundamental system changes, like having to be able to rate for metallic benefits and issue those policies. And that may seem like a simple thing to do, but the amount of effort that's gone in just to changing our systems to be able to do that kind of stuff has been enormous. Not asking for any sympathy. It's just a fact that it's been a huge undertaking, and it has caused some stress in the organization. I mean, I think the morale is high, and we're glad that we're in it. We're glad that we're through that first phase of it. But you know, day to day, if you were to kind of take the pulse of Blue Cross and Blue Shield of Kansas in, say, 2009 and then come back in 2013, it would have looked a lot different in 2013 because of all the changes we had to make. Obviously, 2014, the open enrollment period, the 13-14 open enrollment period was a huge challenge. It was a great learning experience for us, and I think for CMS and for everybody else that was involved with that. And I'm not here to be critical, but you know, we had to deal with a lot of problems that we didn't create. We had a lot of questions that we couldn't answer, that we had to refer back to other people. But the good thing is that we were able to develop and have long had a good professional relationship with our regulator, Linda and Julie and others, that were able to work through those things. And we've been able to establish a good relationship with our contact at CMS that's been very helpful. And so a lot of manual work had to go into getting those things done, and we had to have, you know, humans talking to humans. When the computers weren't talking very well together, it actually helped to have the humans on the phone to be able to work those things through. So that's been fine. 2015 has been better. You know, you haven't seen newspaper articles about problems with the website, and that's been great. A lot of that means that we haven't gotten the same type of consumer calls from people who want to know what to do when the federal website's not working very well. Those are often questions that we couldn't answer for them. We'd have to refer them somewhere else, and that created some frustration with our members, and it was frustrating for us. So that's better, and that's great. That's a real success story that they've been able to improve that, and I think we need to recognize that. It is the truth, though, that the insurer-facing apparatus, the insurer-facing side of this whole thing is still a work in process. It still has some improvement to be made. There's a lot of manual work that has to go into these things, A lot of the transactions we get still have some problems. They're a lot better than they were. They've made a lot of improvements, but there are still transactions that we don't get that we're supposed to, which I think the term that we use with regulators is those are orphan transactions. So someone actually pushed send or whatever and we didn't get it, and various other things. But again, the human relationships that we've developed with our contacts at CMS have helped us work through that. It is still a strange process. So one of the things that's strange from an insurer's perspective is that we are already in the process, because of the way they've set up the rate and filing process, we're already in the process of filing our rates or establishing our rates to be filed in our products for 2016. We know very little about, we know some about what happened in 2014. We don't know whether what happened in 2014 with that cohort is going to continue in 2015, but we don't know much at all about our cohort in 2015, and yet we're expected to rate for 2016. So the process is still something that we're getting used to. So a couple of things. I know I'm getting my 1 minute thing. I think I've answered like 2 of the 100 questions. So the couple of things that you need to know: the 2014 cohort, I think it's probably true for all insurers, I think it's true in Kansas, was less healthy than your average population. At least apparently less healthy, and that shouldn't be that surprising. We closed down the high-risk pools. These are a lot of people who didn't have insurance before, but I will tell you that has come through in the claims data, and it's an issue. It's an issue that we're going to have to deal with. It's an issue that the system is going to have to deal with. We don't know whether the 2015 cohort is going to be healthier, and if so, how much, and what that means about our claims data, and what that then means about rates and tax credits and things like that. The other thing about the 2014 cohort is that a lot of them aren't used to having insurance, and so they have different types of questions, more basic questions than what we're used to. We're used to having people who have had insurance for quite a while, and so we're trying to find ways to give good customer service, to explain those basic issues while still keeping our administrative costs at a reasonable level. And the other thing is, there's lots of things about this cohort that are different. They pay in cash largely, so we've had to adapt to things like that. And so it's a combination for us of some technological issues that we're continuing to work on, some process issues that we're continuing to work on, but also there are just a lot of human issues that we're still sorting out. So lots more to talk about, and I'm sure we'll have an opportunity in the next hour or so.
Okay. KMU, the Kansas Association for the Medically Underserved, on behalf of a Cover Kansas consortium, applied for and received federal funding last year, 13-14, and then again this year from the Centers for Medicaid and Medicare to recruit navigators to help folks with the health insurance marketplace. The application for funding represented associations from across the state whose members can be found at hospitals, mental health centers, area agencies on aging, federally qualified health centers, and health departments. Our consortium recognized early on that if we took the grant money and just hired navigators, maybe we would have 11. And so there needed to be a way we could get a broader reach across the state. So instead, the consortium members looked to their members and asked them to identify folks at their organizations to be trained as certified navigators. And so with that, we just ended this most recent open enrollment period with 105 navigators across the state. We supported them with 2 regional coordinators and myself, helping them through the certification process that involved a background check, and then the online training provided by CMS, and then some supplemental training that our team provided. Again, with the second open enrollment period, the navigators' work focused on helping consumers, first of all, be aware of the marketplace. They did a lot of outreach events. We had 175 outreach events across the state. And then the navigators would sit down with Kansans and help them with the application process, the determination of eligibility to see if they were eligible for those premium tax credits and cost sharing that then would make their coverage more affordable for them. And once that was complete, then they would help consumers with then looking at the plans, being able to review them side by side on the website, compare the plans, read the summary of benefits to them or with them, and then help them enroll in a plan that they would choose that they felt best met their need. It was real important for our navigators to help folks look at the provider network, the drug formulary list, to make sure that what they needed was there for them in the plan that they chose. 58% of the navigators that are with us this year are returning from last year, and 42% were new. You know, navigators are unbiased helpers. Our responsibility is to help folks, and we have people come. Matt mentioned a little bit about people come perhaps not having access to a computer, not having computer skills maybe, not having health insurance before, and our navigators can help them navigate the online website, but also answer questions about terminology and how the health insurance works for them, and what their responsibilities will be, and what their costs will be. This past open enrollment period, we did presentations that were attended by close to 11,000 people, and then our navigators provided direct assistance, sitting down with folks that benefited over 11,000 Kansans. And of those folks that we sat down with, 78% were enrolling for the first time, and 21% were renewing their coverage, and then 1% were coming back to us for post-enrollment assistance that enrolled in a plan but needed some follow-up help. And I think I'll just stop right there. Okay.
My name is Scott Day, and I'm an owner of Day Insurance Solutions. We are a health insurance agency that works in the individual, Medicare, group markets. I am a co-owner of my wife. My wife, Teresa, primarily does all the individuals and families and Medicare, and I'm in the group benefits. I do take a hiatus from group benefits to help with the open enrollment. I'll be the first one to tell you it's driven tons of business to our doors. It's been nice not having health questions, and the website has worked better, but as an agent, the experience is not a good one. I mean, we are going to have to look next fall if we're going to participate in the marketplace or not. And we're spoiled. As agents, we were spoiled. I mean, working with our insurance companies, doing customer service, we're very customer service intensive, and trying to serve our clients in this arena has gotten very difficult. It's very difficult to service. Just things we used to take for granted, like simple address changes, can cause a big problem. And the time intensiveness of fixing problems from the marketplace and from our carriers is tripled. I mean, I'm afraid to have clients call into the marketplace at different times, because we had one call in to check on their income subsidy. They had to prove their income. They sent the information in, and it changed their application, and their daughter got dropped from the plan. I mean, that was a 2.5-hour ordeal getting her back on the plan, and they couldn't do it. I mean, the citizenship cannot get online and do this stuff, and it's difficult even with calling. But our biggest complaint has been the service end. I mean, you do an application, and it's not guaranteed to get to your carrier in the same format. We get permissions. We always get permissions to be able to serve the client. Most of them will give us a 365-day permission, and we will call in with stuff like address changes, and we're not listed. We've had lots of difficulty being tied to the people we help. Where there's a will, we find a way. I mean, now we have everybody do an agent of record letter. So we have it, because there's no guarantee. And our clients that we helped last year, if they make any changes to their plan and they forget to mention us, we don't automatically roll over, either in the marketplace or with our carriers. And so we've lost a lot of clients just by them going on, and that's fine. I mean, they can go do it on their own. I mean, I'm not arguing that point. It's open website to anybody to go do. But whenever they've been tied to us and they're a client of ours, and we try to protect our clients. I mean, they're our clients. They sought us for advice and help. And the difficulty in helping the clients has been the biggest thing that I see. I've also have noticed a trend that we purposely went and helped low-income industries last year. I did a lot of enrolling in nursing homes and stuff like that where we could help the people who we knew didn't have health insurance. And last year, the website was awful, obviously, but we got through it. This year, it was better, but we've already seen the trend. The subsidies, if you qualify for a subsidy, and let's say it's $400 a month subsidy to buy insurance, if you can manage your income and get that maximum subsidy again, $400, that's great. But we're already seeing this trending effect. My client I put in, and they just dropped this week, they were paying $40 a month, had a $400 subsidy. They get another $400 a month subsidy. That's the max they can get. It's based on their income, their age, doesn't go up anymore. But their premium went up $50. So if the premium goes up, and this is exactly what we were told, it went from $40 a month to $90 a month, they couldn't afford it. So I'm already seeing the writing on the wall in that, yes, the low income was greatest served, and we sold a lot of policies, helped a lot of low income people get into them. Affordable Care Act helped our business last year. But I'm already seeing the writing on the wall, and with all the time inclusiveness, medical loss ratio has affected everything. I mean, agent commissions keep getting cut, and customer service, it's outsourced. It's outsourced, and that's not been a fun experience either, trying to get bank drafts set up properly. I mean, we've been fighting a bank draft problem on a couple clients for over 3 months. Everything is just more difficult. And the time inclusiveness and all of this is, we will have to look at it. I mean, I don't know if it's the area for us to be profitable. And we are agents. We are our own businesses. We earn a commission from selling insurance policies. But when everything's getting pinched and our time inclusiveness is growing, we have to look at it. Not saying we're not, but not saying we will. I mean, it coincides with Medicare. We may need to do Medicare primary, and then we'll do Affordable Care Act secondary. Thank you.
Good afternoon. I'm Bruce Witt with Via Christi Health. Via Christi, just by way of background, Via Christi is the largest healthcare system in the state of Kansas. We serve Kansas and northeast Oklahoma through our several of our owned or co-owned medical centers, physician clinics, senior service organizations, and our retail and outpatient services. Since I'm kind of the last one, Matt, I think it was more like 500 questions that Linda sent ahead. I'm only going to try to address one. But anyway, thought I'd just touch a little bit upon kind of the impact of the ACA to Via Christi. I don't know that it has really changed how we deliver care. I think our the biggest impact of Via Christi has simply been in the lower reimbursement we are seeing under Medicare. We're experiencing approximately $25 million in annual reimbursement cuts under Medicare, which was really to pay for the Affordable Care Act. A couple of years ago, we had to reduce our workforce by about 350 employees, and then even more recently, we've taken about 400 open positions just off the board. So you've really seen a reduction of about 750 employees to our jobs to our organization, partly related to the reimbursement cuts and obviously other factors, just some of the changes we're seeing in healthcare. But I think that's been kind of the biggest initial impact of the ACA. We are starting to see some, and we do hire some. We through our parent organization, Ascension Health, we received a navigator grant through our oncology program. So we do employ 4 navigators. We had 5. I believe one of those went into the military, which we're very proud of that person. But We do have 4 navigators as well that do assist folks in finding coverage that are uninsured on the exchange. And we have been able to help, 200 to 300 people do that. So, and I think we're also starting to see some development of ACOs, accountable care organizations. We have 4 different ACOs that we're involved in, 2 for Medicare and 2 for commercial coverage. Just most recently started one with Blue Cross and Blue Shield. So I think that's another kind of impact that we will see going down the road from the ACA. So I think I beat my 5 minutes by quite a bit.
You guys performed admirably. You came in on time despite a little bit of a late start. Thank you all. Thanks for the comments. I just want to give you guys a chance to react a little bit to something that you might have heard from one of the other panelists, or something that they didn't say that you were expecting them to say. We've got tougher questions for you if you can't come up with them.
We weren't really listening.
You weren't really listening, okay.
I was curious on the back end support for a company like Blue Cross, because I know it's been very difficult. Our experience as an agent, and I don't have the insight on how an insurance company deals with it, but we've just seen a lot of trouble getting data between the marketplace to the carriers. I mean, anything on the back end management for you guys?
Well, we have a contact that with CMS, and so it's been a process. We have regular calls with that contact, and that contact goes through the problems they see with our insurers. There's a system that they've set up, that sort of a case management system where if there's an issue that has been called into healthcare.gov, they'll assign it to us and they'll work with us on those cases. And I would say over the course of time, we've developed a good relationship with that person, and so we're able to get things resolved. I mean, it's gotten a lot better, I'll say that. So over the course of 2014 and 2015, from the troubles of the fall of 2013 all the way through the end of open enrollment, there's been a lot of improvisation by the people who are running the federal exchange, by insurers, by regulators, to try to make all this work. And I think what it has caused to happen is by the end, this most recent open enrollment period, there's a lot of manual work that goes into it. It's not perfect, but it's working fairly well for consumers, at least as far as we can tell. Now, there are good problems, and I certainly I sympathize with the issues you've had in getting some answers from them. The problems with the incorrect tax information that were sent out. Those things are going to continue to go on. I don't think it's that surprising, though, that in a project of this size, of this scope, that was implemented as quickly as it was, that we have had some technological issues. I mean, think about all the millions of people that were expected to get insured here. All of the complex information, drawing together product information, demographic information, information from people and companies into a computer system that works seamlessly. That's a huge effort, and so it hasn't been perfect, but I think it's gotten a lot better. So to sort of wrap it up into an answer for you, I think our experience right now with CMS is pretty good. We're usually able to have a good conversation about the issues that we have and resolve them. But it's easier now because we're more in the mode of improvising when we have problems than we were in 2013 and 14.
Matt, you mentioned all the information and how easy it is to get. How have you guys seen the amount of information that consumers have in making choices about picking a health plan? Has that changed at all with the advent of the electronic marketplace and the standardization of the way that information is presented about the health products, the insurance products that they're buying? Do you think the quality and availability of information is better than it was pre-marketplace implementation for the patients you deal with?
In many cases, yes. So one of the problems with the individual market before the exchanges was that it was relatively difficult for an average consumer to go out and get different product information from the different companies, understand how the cost sharing translated into real value, and understand whether they were making a good decision based on the price. We're really good at thinking about price, whether it's for green beans or a car or insurance. The problem with that insurance part is that it was hard to compare the information to know whether you're getting a good value or not. So I think it's improved, but there are still some problems. It's still relatively difficult, I think, for consumers. I think this has been borne out in the experience that regulators and others have seen, for consumers to fully understand what goes into that product with things like network, right? So if there's a limited network product, what does that really mean? What does it mean? Because you don't necessarily know where you're going to interact with the healthcare system. And so that's one thing that I think could really improve. And I think, given that consumers, a lot of these consumers are still new to the process, even the improved information that they can get on a computer screen that seeks to compare apples to apples is still hard for them to understand fully. I mean, a lot of them, if you ask a reasonably sophisticated consumer out there to tell you what the difference is between a deductible and co-insurance and a copay, quick, say it. I mean, they're not going to know necessarily if they haven't had a lot of interaction with the healthcare system. And so it may be that it continues to improve over time. We as consumers, to the extent that it becomes a more individual marketplace, become better at understanding what's important in a health insurance product. So it's a long answer, but I'd say it's improved, but there's still a long ways to go for it to be what we really want it to be.
I'm going to follow this theme a little bit and go to the other end of the table. This idea of different kinds of insurance products, higher copays in general, the issue of how much people have to pay up front, were they expecting that? They have insurance. Many of these people may not have been insured or insured in the private market at least. Some of the rules are different. There's been some concern of, will there be more of a sort of underinsured situation? People who may have insurance but then have a high copay or high deductible amount. Is that coming across in the kinds of inquiries that you're getting at KID or in the providers at the point of service?
I would certainly agree that we hear from a large number of consumers who really don't understand the basics of health insurance. I just came back last night from the NAIC meetings in Phoenix, and at the Consumer Liaison group meeting there, this was a big point that was raised about just educating the average consumer about how what the terms mean and how they work in practice. So I think that that's a big concern, is just making certain that people understand what they're buying and then how it works in practice.
Okay.
Well, I have a gentleman from Via Christi here. I'm going to look at him and make sure I'm answering this correctly. But I think the trend that we've seen on the provider side is, or even in the insurance market, is movement to more higher deductible plans, and that's been going on even prior to the ACA implementation. So we are seeing, more challenges on that end and collecting the kind of that uninsured part of the health insurance plan, the deductibles and higher co-insurance and those things. So it has an impact.
I might just add that last year we had a number, people were very interested in those bronze plans. They liked those low premiums. But this year, a lot of those very same people were back after living with that for a year, recognizing that they needed to use their coverage, and so made the change this year. The other thing, the network issue, I think is huge. We're seeing a lot of people who enrolled on their own, didn't look at their provider network, and now they're coming back to a navigator. Oh my gosh, my doctor's not on I can't see him.
Debbie, you mentioned, no, I'm sorry, it was Julie, mentioned the average premium based on the plans that are being offered. But then I think an important question is, what are the plans that are actually being selected? And there were some low-cost entries in the marketplace this last year that brought down the average premium. But it'll be interesting to see and compare. Maybe the plans have already started to do that. What product selection are people making, and is that changing over time as people do become more familiar, more aware of how their insurance product is working? But any comment? I don't know if you guys have looked at that in terms of enrollment trends, or the types of products people are picking beginning to change. Is it too early to see that?
I have not seen any of the demographic data yet. I don't believe it's available. Probably won't be until we finish up this open enrollment period that's going through April. But Debbie may know more about what she's seeing.
I just see a trend that year two, you look at it a lot more about what your coverage is going to be versus what the premium's going to be, what your out-of-pocket's going to be if you do go,
Okay.
versus waiting for the worst-case scenario.
I'd like to weigh in on this one. We're seeing, it all depends on where they are on the income scale. If they're in the right pocket and they get the maximum subsidies or close to, level 5, level 6 subsidies, they're all buying silvers. I mean, you hit that right pocket and they're getting that silver and they're getting a Cadillac plan. Because if they're in that 250% pocket of income, they're getting their deductibles lowered to nothing. They only have $1,500 out-of-pocket maximum. They're getting free brand name drugs. I mean, the plans really become a Cadillac at that silver price. But what I referred to earlier, and we're starting to see this too, even those people, because that lady that I mentioned that had a $40 premium that went to $90, that was a silver plan. She was in the pocket, but she couldn't afford $50 more, so she told us. Now, she was not interested at all, because we flipped and showed them the bronze plans, because that would be a free premium, but she didn't like the huge out-of-pockets on them. And we sell mainly bronze to young, healthy people looking for nothing but insurance protection at a low cost. And it just all depends on where they are on the income. Most of our people who don't get subsidies, middle-class families, they'll buy bronzes. People on the upper end of the middle class will buy golds and silvers, but that's rare. Most of our pocket has been in the silver and bronze range.
I want to ask one more question before we take questions from the audience, but have you seen any impact, and if so, what, on the general insurance market from the marketplace plans, the things that we've been talking about? Bruce, you mentioned some Medicare reimbursement issues, which are even outside that, but has there been an impact, a perceptible impact to you in the healthcare market that you guys deal with as a result of the introduction of the marketplace plans, the subsidies, the new types of benefit structure, those sorts of things?
Well, we're not seeing a lower number of uninsured patients coming to us. And I think there was a statistic that was published here recently, the state of Kansas, the overall uninsured rate actually went up in 2014, not down. So that's kind of what we're seeing at Via Christi as well. We're still seeing the same levels of charity care that we're providing and uncompensated care, so that's not changed yet. And partly because we haven't really fully implemented the ACA. We've only implemented the exchange part of the ACA.
Yeah, I don't think that, I think it's way too early to say how it's going to affect the rest of our book of business. And we've had, we don't give out enrollment numbers unless we absolutely have to, unless Julie forces us to, which we'll give them to Julie. But we did fine in 2014. Our numbers are larger than in 2015 in the individual market, both on and off exchange, and that's not surprising. It's probably true for about everybody. I think the 2015 cohort will be bigger. The question will be how many small employers in particular will stay in the marketplace. And there's been a long-term trend, not speaking about our book of business, but just generally in American health insurance for fewer small employers over the course of time to offer those benefits. And one of the big questions is whether the existence of the exchange will accelerate that trend, because if you have let's say you've got a gas station, you employ 7 people, you've had some guy named Ted who's been filling up the wiper fluid for 15 years, and he's uninsurable, and so you don't want to end your small employee plan or your small business plan because Ted won't be able to get insurance. So there was a moral cost to that before, and now Ted could go to the marketplace and get a subsidy and be able to get coverage, guaranteed issue, and if he qualifies for cost sharing reductions, it'll be a pretty good plan. We haven't seen any of that, I will tell you, in our book of business so far. And what we've seen is businesses in general, and I think small businesses in particular, kind of hunker down for a while and just see how all of this settles out. They want to keep the plans, whether they're grandfathered or grandmothered, which is the other type of plan that's out there, at least in our book of business, as long as they can. And we've been doing what we can to allow them to do that. But I think over the course of time, that's one big question. The other big question, another big question, is how this cohort, the individual market, continues to evolve. Like I said, 2014, relatively old, relatively high claims experience, relatively new to the insurance market. Not always true, but generally that's true. 2015, too early to tell. Wouldn't surprise us if it's somewhat younger, if it's somewhat has somewhat less of an impact on claims on the system. So they have fewer claims. And 2016 more of the same. But we don't know yet. And so I think it's going to take us 5 years or more before we really have a good handle on what this thing is going to look like when it settles down.
Before I let you go, I'm going to, of course, ask you to prognosticate on 5 years from now and the
Great.
Supreme Court and things that may come down the pike. But for now, I want to turn to the audience and take questions. And I also just want to, we have a lot of people with great perspectives in the audience. I want to just particularly welcome Stephanie Moore and Adele Sink from the regional office of HHS and thank them for being here today. And we've heard CMS and HHS mentioned a lot, so hopefully they'll chime in, and certainly they're here to talk to you if you have questions. But what questions do people have? And let me, I heard a great quote at a conference I was at recently, which the moderator asked the audience to please frame your passion in the form of a brief question. Okay, so if I could ask that of each of the audience participants. Ira.
From my point of view, the heart and soul of medicine and everything we do is the relationship between the patient and the doctor, the interaction between the patient and the doctor and other healthcare providers, the relationship between the patient and the hospital when they need help. I'd welcome some discussion and comment from the panel and others. Has the ACA facilitated healthcare in that way? Has it gotten in the way, or has it stayed the same? What about the patient and the doctor together in the consulting room? Thank you.
Good.
Bruce, you're the
Well, and I think I kind of made the comment in my opening remarks. I don't know that we're seeing a dramatic change in the patient-physician relationship, or I don't see the ACA, getting in the way of that. I do think there are opportunities that we're starting to see with accountable care organizations and a movement to more population health management, trying to keep our population healthy versus only treating them when they're sick. So I think there are some positive signs from that regard and I think some of these we've done a patient-centered home pilot project where we've at least over a year's worth of data, and we're starting to see we've reduced the overall cost of that population by 12%, reduced unnecessary visits to the emergency room, and reduced just overall hospitalization visits. So I think there are some good signs from that regard. And I don't think overall I don't think we've seen any dramatic change in how we treat our patients.
I will say, I don't think the first wave or two, whatever wave we're in right now of the ACA implementation really sought to do what you're describing. But to echo what Bruce is saying, I mean, if we're going to get a hold of healthcare costs, if we're going to resolve them, we're going to have to change the way that doctors and patients interact and the incentives that doctors and hospitals and everybody in the system has in terms of the type of care that they give. And so that's not a problem. It's a problem that's been around for decades, as you know, Ira, and it's going to take a long time for it. If we're going to fix it, it's going to take a while for us to do that, because it's really it's not just reform of the type of products that are offered and how much they cost and what the apparent cost is to consumers. That's really a reform of a complex set of interactions. We're on our way. We have a project with Via Christi to try to begin to change that, but it's not going to be an easy thing to do. And I think that would be too much to probably ask of this law so soon.
Great. Other questions? Yes.
My question may be a little off the mark, but what are you seeing looking into the future? I live in a town in southeast Kansas that's probably close to losing a hospital. What are you seeing for rural healthcare coverage? I mean, we have trouble attracting doctors, may lose healthcare. The town's about 10,000 people. Looking into the future, what do you see the impacts are going to be for rural parts of Kansas?
Well, I can tell you, we have every hospital in the state, in our service area. We have 2 counties and not in our service area, but we have every hospital in our network, and so we hear and feel that issue a lot. And I don't think this law, I don't know, I haven't really seen a whole lot of literature on that specific issue about what it'll do for rural America. I do think that it's a problem, and it's a real challenge for a community like Independence to be able to support a hospital and have doctors and have the type of healthcare system that we all believe that families ought to have, whether they're in Independence or Kansas City or Wichita or wherever. You know, we only serve those 103 counties, and so it's our focus. And because we don't have 2 of the urban counties in the state, I think our focus as an insurance plan is a lot more geared towards small town and rural Kansas than most insurance companies is. And so it's a problem that we think about a lot. And I can't get into the details of the way we reimburse our providers, but I can tell you that every year when our provider relations staff goes before our board, it's a topic that comes up. What are we going to do to make sure that there is still access to healthcare providers, that their business model is still sustainable? And there's only so much that we can do, though. There's going to be a lot of decisions, I think, that small communities are going to have to make about how to make that work. So I don't think the law, at least the wave that has been implemented so far, I don't think it's doing anything to help or harm rural America in terms of their healthcare system. But the issue is still there.
Bruce, you look like you were going to jump in.
Well, I mean, and clearly, and, you know, there's obviously been a lot of discussion about it. One way that could provide some assistance to rural hospitals is expanding our CanCare program. I think that would bring some financial relief. I'm not saying that's going to, those that may be on the verge of closing, that's going to keep their doors open or not, but I think that would be one thing that's under the law that would provide some assistance to hospitals, but we all know what the challenging parts of that discussion are, and what it may cost and those kind of things. But that is something that would be helpful.
I think it's hard. The challenge also is sorting out how much of all these changes you're talking about on the provider reimbursement, on lots of aspects of delivering care and rural hospital sustainability, how much of that's due to effects that were already in motion and beginning to play out, how much is specifically related to aspects of the ACA. But certainly there are challenges ahead for rural healthcare in our state and other states. And yes.
To piggyback on that question, what effect do you see that this will have on, like, our safety net clinics that we have in some of our smaller communities? Salina, I know, has the Salina Healthcare. It's been a fantastic program for those, who can't afford a lot of medical expenses. What impact do you see on safety net clinics? I know they are really looking for Medicaid expansion, but as far as this CARE Act, what do you see?
I don't know if there may be some other folks in the audience that might be better equipped to answer that.
Some CAMU folks. Where's, yeah. Denise?
Yeah, go for it.
Well, I'm Denise Sisman, the new executive director of the Kansas Association for the Medically Underserved, and we also have Kathy Harding here, who's the previous director. You're absolutely right. Medicaid expansion is essential for our safety net clinics. They have 50% of their patients that they serve do not have health insurance, and we're looking at about $44 million of uncompensated care just last year alone. So, we did an estimate earlier in the year when we were preparing for this, and we thought if only half of that care could be compensated, we're looking at $25 million. And especially in some of the more rural areas, the safety net clinics that are serving those populations could be impacted dramatically. They would be able to provide additional services.
they would be able to serve more patients, and they would be able to create more healthcare jobs.
I have a question.
Yes, who said?
I said it.
Yes, please.
So without expanding Medicaid, Bruce, so in Wichita, where I represent, Via Christi, Wesley Medical Center, so those who come into your emergency rooms and your discretionary funding to pay for their services, where are you at on that and how?
Well, I mean, we continue to see, you know, without expansion, we're seeing the same level of uncompensated care, same level of uninsured patients coming to the emergency room. And so I think the charity care that we provided across all of Via Christi last year was about $41 million. You know, that's, I don't know if I'm answering your question or not.
You are, and the point I wanted to make is those individuals that come into the emergency room and they can't pay the hospital, and eventually they get that letter in the mail or that phone call from the debt collector, and it's just a vicious cycle.
Let me build on that a little bit and see, one of the concerns that was out there is as the ACA is implemented and subsidies are available for low-income people and Medicaid expansion in many states for the lower-income people, that the system may be less sort of willing to provide charity care, so to speak. You know, if the expectation is that affordable insurance is available, that maybe the community of providers may be less willing to provide, not the safety net clinics specifically, but private sector doctors, emergency rooms, those sorts of things, and it could affect access. Is there anything to that concern? Is that played out in any noticeable way in communities?
Well, I mean, by federal law, we can't turn someone away because they're uninsured. So I don't. You
can't turn them away in the ER with EMTALA and all that,
right.
But there are a lot of ways that private providers have of limiting appointments, the number of new patients that they'll take, those sorts of things. So again, it's just a concern that's been raised that the culture may change to the extent that the expectation is that everybody should have insurance and contribute what they can, and if you choose to remain uninsured, you'll not only pay a tax penalty, but maybe have a harder time getting other services.
We haven't heard of that happening. I think the atmosphere around the law is unsettled enough still, even after a year of full implementation, that I don't think the culture around those types of issues has had time to change. And I don't think there still is a sense that we know what the future of the ACA is going to be. And so I'd be surprised if healthcare providers had made dramatic changes around those issues. This one we certainly haven't heard of.
I'm kind of reluctant to step on the Medicaid expansion discussion, so if anybody has anything they want to say. But I wanted to get back to something you were talking about earlier about kind of health insurance literacy, people's ability to understand what they're buying. I mean, something we struggle with. Remember, I asked a similar question last year, and Scott, your response was, we just can't explain this to people. They can never understand it.
We explain it, they just have trouble understanding.
So the issue, I mean, that sort of describes, I'm thinking back to Economics 101, that describes the classic product that needs to be regulated by government, the product that consumers can't understand. So what is the role here of where government should step in and where the private sector, maybe this is for you, Matt, should step in, because you also mentioned that it's very difficult to explain your products to people. How are we going to, I mean, people are spending a lot of money on something they fundamentally don't understand. They don't understand what the value of it is. They don't understand what they're getting when they buy it, and they don't understand how to use it. So how do we get through this?
I guess I wouldn't go quite as far. I certainly didn't intend to go quite as far as I'm hearing you say that, Sheldon. And it is regulated. I mean, my goodness, the federal exchanges are as regulated as it's ever been. I mean, we can only offer products within certain actuarial values, and the whole idea of that regulation is to allow consumers to make meaningful decisions based on cost. My point is that I don't think we know yet how well it works. I think we know in the first year or two that there still are issues that consumers don't understand very well. I think that's true for industries other than health insurance. I mean, there are lots of things that we're not, that I as a consumer, think I hope I know enough about when I buy a new air conditioner for my house. I hope I'm getting the right one. Health insurance is a particularly complex one, so it shouldn't be surprising that we still have challenges in allowing people to understand it. What I think we need to do is find ways, if we're going to go forward with these exchanges, if they're here to stay, if we expect them to be a vehicle to allow consumers to make meaningful decisions, we still have work to do to make sure people understand what they're buying. I think it's a lot better than it was, and I do think it's possible that a substantial portion of the population that buys their insurance on the exchange, as they take more ownership of that decision in time, will get better at understanding what they're getting. It'll become more predictable to them. I think the issue of networks is a different one. I think there probably needs to be a way to explain things better on the exchange than is explained now. It's not meant to be critical of the way they're setting up the exchange. I just think our experience is that even with our product, with our solutions product, which is a relatively broad network product that has a few changes in it, we've already, in the first few months, had some issues where people didn't fully understand the nature of it. So my only point, Sheldon, is I think we just need to continue to improve it. I don't think we should be defeatist about it and say that it's impossible for consumers to understand and that they never will. I just think it's a new era, and we're asking consumers to do more, and we're not quite there yet.
And certainly the challenge doesn't stop once you get them to sign up. There's a lot more education that can be done.
Thank you. What I've heard so far is that this is a very complex challenge. You've got consumer behavior, provider behavior, changing business models, all that wrapped around. Are we just going to muddle forward for several years, or are there benchmarks that you can identify that would tell us that we are moving in the right direction?
I think that's a great question. It's a tough one. I'm pausing to think and eager for others to jump in.
Yeah.
I mean, it sort of depends on what your goal is. I think we have made progress. I think there are a lot of consumers. It's absolutely true that there are a lot of consumers in Kansas, whether that insurance number was uninsured rate is right or not, who have insurance today that didn't have it before the Affordable Care Act. And we know, I'll tell you, we know that they're using the health care system. And so they're getting care that they believe they need. And I think in almost all cases they really do need. And so that's progress. I think, we're just in an era where we don't have consensus about what the goals are in the healthcare system. And looking at it in a bigger picture sense, I think what we all want, though, is for there to be more people who have access to affordable health care, and for healthcare costs to be sustainable in the long run. And I think that is probably too much to ask of this law. It's not going to be able to solve both of those problems perfectly, at least the way it's written right now. And so I guess part of my answer is yes, we are going to muddle forward, and I don't think we have any choice. But I don't think we should deny that there are some good things happening, and some of those things are the result of this law. But I also don't think that we should assume that this law was meant to solve all of those problems. See, the thing, when things are in the political realm, by necessity, the people who are promoting them have to talk about them in sort of grandiose terms. This is the answer to healthcare and health insurance. Well, it's unrealistic to expect this law to solve all those problems. And so I would take, if you're trying to figure out whether we're making progress or heading in the right direction in healthcare and health insurance, I think you're going to have to look at a broad set of data points. Now, some good news, and I don't think we can fully explain it yet, is in recent years, the rate of increase in healthcare costs has been low by historical standards, and what's been interesting is that it's been low for several years now. And they're competing, that's really the fundamental issue. If we want to solve the issue of healthcare access and cost, I mean, it's really what's the rate of growth in healthcare costs across the whole space. And it's been in the high twos, low threes for several years now. Competing theories about why that's the case, but that's good news. And if we can do that, if we can continue to keep it at that rate on into the future, I mean, that will relieve a lot of pressure on the system in ways that this law probably by itself can't do.
Stephanie, do you want to say, okay. The benchmarks, good.
Well, I guess one of the things I would say is, for us, working with consumers, we certainly are miles ahead of where we were a year ago. And the kinds of questions that people coming back to us the second year, you know, there's been a big learning curve. They've had coverage, they've used it. So I think those kinds of things are gonna continue to go forward. It's only year two. I know last year the navigators were asking for a lot of things that we couldn't give to them, explanations in a simple to read form. And this year CMS had those things available. There really wasn't much that we would look for that we couldn't find. And so I just keep thinking if everything can continue to improve like that does. Now those aren't necessarily benchmarks, but again, it's only year two.
Other thoughts about that? I think we have time for another question. Is it?
Well, there was a
Cindy?
question. I was just going to respond that this is passion into simple here, Bob, for you. But I have two sons, one 29, one 33. The 29-year-old is actually talking to me about his insurance choices, right? So we've made progress because we've awoken a 29-year-old up to the fact that he needs to be paying attention to his own situation. The 33-year-old never even talked to me or never even had insurance until he moved up to Seattle and got his job with Amazon. And then he was lucky enough not only to have the system here, but he lived in the UK for 2.5 years, so if you ever want to hear a good story. It was positive, so I'm not going to make light of that. There was some differences in children being born, but it was a positive experience overall. But the thing is that if we have forced young people to pay attention to what's going on, I didn't give a rat's ass about health insurance at 29 years old. I already had both my boys by that time, so who cares? But the other problem is that it's too difficult of a system right now to figure out, because I have a 29-year-old that is very computer savvy, and he has a lot of trouble dealing with the insurance company. We're not going to use, apologies to you, Mr. Day, but the day of insurance folks are kind of over with, because that to me is a supplemental thing on top of, we don't necessarily need that situation anymore. But the system is too difficult right now for the young people to continue to figure out. So there's some problems there. Because Chris is pretty bright, and he says he has a lot of trouble. And he already got kicked out of one because he didn't pay it right, and so we've got it figured out now that Mom's helping him pay it right. But that's a positive, Bob, right?
Yes.
Young people think about insurance. Maybe I'll get it right.
Great. Sure, go ahead. And then I'm going to wrap it up here so we can get it.
My question is probably for Matt, that you mentioned, I think there's still some legacy programs around. Do those disappear and everybody's going to be on ACA at some point, or some?
Yeah, sure. So one of the things in the law, and I didn't mean to cut you off, you hadn't asked one of the things in the law that it is grandfathered coverage. So if you haven't made certain changes in the coverage that you had when the law was passed, then you can keep it. And a big chunk of our book of business remains grandfathered because people just have decided they're nervous enough about the changes, about what it might mean for them. They don't want to change yet. They probably will someday over the course of time. And there's no expiration date on these grandfathered policies, so you could theoretically keep it forever. What'll be interesting is over the course of time, will people become more comfortable with the ACA and less anxious about changing into a metallic program, or metallic policy, full ACA compliant? We don't know the answer to that yet. So far, they've been staying in place by and large. And then the other part is this grandmothered coverage, which I don't know if we have enough time to get into. We certainly probably don't. But there's a chunk of coverage that's non-grandfathered that isn't fully ACA compliant. That was sort of a make-do thing at the end of 2013, and we had a fair number of people decide that they would keep their grandmothered coverage too. So both of my grandparents were involved in this. Surprisingly, I never imagined they were involved. So I think so far, like I said, I think people have tried not to make a mistake. I don't want to lose my grandfather coverage. I don't want to lose my grandmother coverage. I can always change, and I can never go back. My guess is that'll last, at least with our book of business, for several years.
I know we have Kevin and Candace in the audience, and that's consistent with what you're seeing in your companies as well.
Yeah, this is Candace from United. We were on a healthcare exchange this go around looking, working with the department and looking at it for the next 2016, but I don't expect that the current
actually relatively new to the individual market. So at the end of 2015, we rolled everybody onto an ACA plan. So if you have a Coventry plan, you're on an ACA plan on an individual basis.
Well, I just want to throw in a minute, maybe I misunderstood the question a little bit, but we're only talking about people who are in the individual market for health insurance, which is a very small proportion of the number of people that have insurance. So all the employer-based plans and all that are not directly affected.
Well, there's grandfathered plans in all the group business. The grandmothered plans, I'm gonna get lost here, in small group, we've got a bunch of small group plans that are grandmothered. So, but yeah, primarily I suppose over the course of time, actually I take that back, it's gonna affect all of them. We have a lot of small business owners who've chosen to stay in grandfathered coverage because they just don't wanna change. But it won't affect the large group because they don't have metallic benefits. It's the small group plans that will be affected by it.
Thank you all. I want to give them a round of applause. And thank you all too for great questions. As a parting question, I want each of the panelists just to make a comment about this. Last year I was very struck at the level of uncertainty that existed around almost every aspect of the ACA and how it was affecting business planning for hospitals, for insurers, for people trying to sign people up, for small businesses, big businesses. There was a lot of uncertainty. We're a whole year farther down the road now. Tell us your plan related to what you're anticipating in the next 12 months related to the ACA, and is the level of uncertainty increase, decrease, stayed about the same in terms of affecting your business operations as an organization, as a company? We could start, well, I'll give you a relief. We'll start down here, come down this way.
Well, I mean, I think there's still considerable uncertainty with the Supreme Court case that could impact the federal exchanges. You know, the fact we haven't moved forward in this state with expansion, it's still a question, you know. Don't know if we will or won't, but that, you know, those are issues like that that are still kind of hanging out there that makes it uncomfortable.
From the department's perspective, we will be doing plan management again for the 2016 plan year. The filing deadline for binders, rates, and forms will be May 1st, so we'll be moving forward with those components.
We are looking for exit strategies. I mean, it's unsustainable as an agent. I mean, and there's comments like agents are on the way out. There's a general perception of that, and I see it. The opportunities are going to be in filling all the gaps of the problems of the ACA, and that's what we're moving to. I mean, the plans have huge out-of-pockets. So we're already finding products coming out in the markets that fill those gaps. I mean, there's tons of compliance issues. I mean, we'll probably move to more of a service type program where we help people with the problems that they're facing in the ACA. I mean, compliance in the small group market is immense. So it's going to be moving to a more consultative basis as an agent and helping employers, individuals with the compliance, because the compliance is never ending. I mean, it's there. I mean, I'll get a lot of small business owners will call up, they got 10, 12 employees, and they're wanting to maybe offer group health insurance, and my question is why? I mean, do you know what you're stepping into with all the compliance?
Versus just sending the employees to the marketplace?
Correct.
Yeah.
I mean, Day Insurance Solutions dropped our group plan last year, and I breathed a huge sigh of relief because I no longer have to comply with ACA, ERISA, and HIPAA. I mean, those are huge compliance issues for small employers just because they offer a group health plan.
Great.
So the compliance piece in the small group market is the secondary piece that will weigh on small business owners.
Great.
Besides the price. I mean, the price is still getting up there. We're still trying to fight to get them low-cost insurance. And we will do group benefits. That's going to be our flagship, that with Medicare. But it's going to be a transition in filling the need that people are going to have from these policies.
Debbie?
Well, certainly the items that Bruce mentioned are on our mind, but as is perhaps, will there be another year of funding for Navigator projects? But we are just planning like there will be. We'll go forward with our plans and be flexible enough if we have to change. But in the meantime, Navigators are here to help.
I would say there's tremendous uncertainty. There are some things that are more certain. I think we understand how to interact with the exchange. I think we've gotten into the rhythm, sort of the annual rhythm of filing rates and understanding how open enrollment is going to go. Those things I think are more settled within our plan. But the larger political and legal context in which this set of things rests is uncertain, and it's as unsettled as ever. I think King v. Burwell could have a huge impact on the individual market, because understand that it's not just about the subsidies in the exchange. It will have a ripple effect throughout the individual marketplace, because the adverse selection that will likely take place if you don't have any tax credits in the exchange. And I don't know where that goes. I don't know where that goes I know we've got United and Aetna in the room. I don't know what it's going to look like if that happens. And so that's something we're having active conversations about, and that is as uncertain an issue as we have faced so far with healthcare reform. So if you can tell me how Anthony Kennedy's going to vote, then I'll tell you what.
All right. Well, again, thank you all for coming, and thanks to the panel for a great conversation.